sure to turn it over to your session facilitator, Dr. Van Bossa. So feel free to unmute if you like and get us started.
Absolutely. And so on behalf of everybody at AMCSI, particularly the board of directors and everybody who's helped put together this virtual conference this time around, I want to welcome you to our 16th annual conference. This is our second annual virtual conference. We're hoping that it does not remain an annual event as a virtual, next time in person. So while we may be hosting this event virtually, we know that we are all together in heart, even when apart. So I am serving as a moderator for this session. I am the medical advisor on the board of directors for AMCSI and have been a part of AMCSI since the second annual meeting. That's actually when I got involved. I heard about AMCSI right after their first meeting when a mother of a patient I treat came up and she goes, "You really should know about this group. Why don't you check them out? Why don't you reach out to them?" And so I did. And I said, "Hey, next time we got a conference, can I talk?" And they were nice enough to let me do that. And now let's see what they've fallen into, huh? Anyway, if I can move ahead in slides to the next one here, and just say that we've got a really interesting virtual conference here that's running from July 18th until the 24th. And each session includes 2 different presentations by medical or other professionals working with individuals who have AMC. Registration is required, but of course this is free. It's open to anyone who wishes to attend. And AMCSI is also live streaming portions of this event online. So some of you are joining us by Facebook right now. But we really want to make sure that everybody registers us so you can join us live on Zoom as well. And we are recording these sessions and they will be available in time, I think, on our website. I'm not quite sure what the details of that are. And go to our next slide. Oops, hang on a second, I might be off by a slide here. There we go. So today we have 2 talks, but before we get to that, let me just say real quickly. So the conferences go all the way through until Saturday, and you can see on the slide before that I had poor Jean skip over. You can see that we have the remaining talks this week. So tomorrow we have a couple of interesting talks set up. So you can see those are group efforts. On Friday is the David and David show. And then on Saturday is our last session. And we'll look at that. That's me presenting there. And we talk about some spine things. And then I get to segue with the rest of the group into the closing ceremony. And guess what happens then? We talk about where the 2020 annual conference will be. So that's pretty exciting. Now, going to that next slide. Sorry, Jean, I got my little speaking thing in front of me here, so I can't see what slides you're on necessarily. So here's a quick overview of our agenda today. We're going to be starting off with Dr. Dan Zlotlow talking about upper extremity issues. And immediately after that presentation, we're going to have a brief Q&A so everybody can ask questions of Dr. Zlotlow and try to stump him. And then we want to make sure that everybody knows that those questions, you need to send those in. You can put them in through our chat window to our technical moderator, and Jean can then send those through to us. And then after that, after a brief intermission, we're going to have our second group of speakers. There's actually a team event when they present their work on research going on in arthrogryposis. And then we'll have another Q&A session, and then we all wrap it up and go out for drinks later on. Oh, sorry, that was my plan. But anyway, let's talk a little bit about AMCSI. So AMCSI is a nationally recognized 501c3 nonprofit whose mission is to provide and encourage more understanding and mutual support among anyone affected with the diagnosis of arthrogryposis multiplex congenita, or as we all affectionately know it, AMC. As well as AMCSI is looking to create a higher standard of arthrogryposis awareness by means of conferences, meetings, studies, and any other way that you want to suggest to us to do that. We're all about awareness. And with that in mind, we want more people to become members. And Jean, I think you've got a questionnaire about this, right? A poll. I guess I get to, oh, Jean launches poll. Then I get to say, we have a poll here, which is going to ask whether or not you are a member of AMCSI. You might see the little poll there. So you're Options are yes, no, or not yet, but I plan to join. So hopefully we got a lot of yeses and some not yet plans to join, and not too many of those no's. That'd be really upsetting. Oh,
Well,
there it came in.
Yeah, it looks like a lot of people are members. Woohoo! But a number of you are planning to join, so we're glad to hear it.
Super. All right. So remember, if you're interested in joining AMCSI, please look for the link in the chat that Jean just put up. And remember that our members get discounts and early bird access to AMCSI events, and you get to be part of a really cool club also. And then there are also plenty of ways that you can help AMCSI. And Jean's going to catch up in a second with the slides here. Sorry, Jean. There we go. So there is PayPal Giving Fund. eBay has a charity type thing. Amazon has got Amazon Smile. So please, whatever way you're able to help us out, we really want your help, because realize that there's so many different things that AMCSI does with the funds that we get. We put on the conferences, and remember, this conference is free, despite all the work that's being put in. We also help out with outreach, with grants. There are scholarship grants for students. There are hardship grants, and there are some adoption grants. So we're really trying to help our community in as many ways as possible. And the more feedback we get, or the more input we have from you, the better it is for all of us. So thank you very much. So now we have another poll that we're going to do. And this one is the Let's Learn About You poll. So we have a few questions here. You see, we just got another poll window that came up. I want to see where you're joining us from. Are you from the Northeast US like I am, the Southeast US, Midwest? Are you out in the West where you're making s'mores out in the forest? Or are you international? So let us know.
All right, and I can see the results as they're coming in, and it's an interesting distribution this evening, very different than our other nights. So this is, I think people heard me, and now they're all taking the poll seriously because these numbers are now shifting a bit. That balance has moved. All right, well, with that, again, I'm looking at about 70% of you having responded. So I'm going to end the poll and let's share the results. And so we now have a large representation from the Midwest US. We have some international attendees, and again, some over on the North and Southeast, but in previous ones, it was heavily represented on the North and Southeast. So we're glad to have those Midwesters coming in. And then it looks like, again, we have a really large representation attending because they have a child with AMC, but a number of adults or individuals with AMC are on the line tonight. And then we have a number of other medical professionals who are joining us. It looks like they care for someone with AMC, and again, other interests, including people who are just curious, or they work or love someone with AMC. So thanks for sharing. So
I think Harold is muted.
Yes, Dr. Vambosa, we just missed that fabulous intro. And so this is your chance to reset and do that one again.
I was actually saying that I wanted to apologize if I offended anybody with my little joke about the forest fires out west, because that probably wasn't joke worthy. But I noticed that nobody from the west said that they were here, and I figured that might have been the reason. So pardon me for doing that. Anyway, let me get back over here, and I think we are on to our next slide. So we're on to our first talk today, and our first speaker is Dr. Dan Zlotlow, who is one of my partners. He's a pediatric upper limb and peripheral nerve surgeon who is at the Shriners Hospitals, both in Philadelphia as well as in Greenville, and he also spends time up at the Hospital for Special Surgery in New York. And he specializes in the care of patients with arthrogryposis, as well as those with brachial plexus palsies, peripheral nerve injuries, spinal cord injuries, complex post-traumatic deformities, congenital differences, and limb deficiencies. So I have known Dan for nearly as long as I've been at the Shriners Hospital. He came shortly after I came there, and very early on threw his lot in with me with these challenging children who have arthrogryposis, which was really great. Because before that time, I was the guy who's doing the upper extremity stuff. So he has taken it to a completely different orbit. I'm still on the ground, and he's way someplace out in stratosphere with all the exciting stuff he's done. He leads medical outreach missions. He's been to Havana, Cuba, Kigali, Rwanda, and he's also founded 3 professional societies. So he's not a guy who rests on his laurels. He's very busy. He's written a lot of articles on arthrogryposis, is one of the leading authors on the subject, as well as written articles, books, book chapters, and spoken internationally. So I want to turn the camera and the microphone over to Dr. Zlotlow so that he can begin his talk.
All right, thanks, Harold. Really appreciate the introduction. Certainly, Harold needs no introduction when it comes to his involvement with children with arthrogryposis and his commitment to this group as well. And I would say completely unbiased for those of you who are thinking about joining this group, and I have really no involvement other than, well, some involvement. But it is, I think, the best, and I really mean this. I think I deal with several other conditions that have support groups, and I will tell you that there is no better organized group that does more for its members and really cares about, I mean, if you look at this session, if you look at this entire conference of trying to get really top specialists in their field to educate parents and children, and you're getting basically a second opinion online, and you're educating yourself so that you can ask better questions of your doctor, of your therapist. And I think it's tremendous value that they provide. And I think it's an organization worth supporting and worth being a part of. So unsolicited, really, but thank you guys. And really thank you for what you do. So with that, I will say that, as Harold said, from relatively humble beginnings, and I think that we've come a long way in the treatment of the upper extremity. And I think the treatment of the upper extremity in AMC has really been the redheaded stepchild of AMC treatment. And I think there are so few of us around the world that do this at any high volume that it makes it difficult for us to really make a lot of progress, because everything is very slow in coming. And obviously, it's a rare enough disease, or condition that we really, it's important for us all to be friends and for all of us to work together towards making this something that we can get past and we can improve as much as we can. So
Dr.
with that,
Z,
I'm going to, yes.
share your screen.
I'm working on it.
There we go. Thank you, sir.
Sorry. I was just doing I was on Harold's introduction. All right, we'll get going. So with that, without further ado, you've heard about this. What's arthrogryposis? It's basically a descriptive diagnosis, conjoint contractures in 2 or more areas, and they may have other issues as well. The most common, I think by far, is amyoplasia, which is about 1/3 of cases. And this is sort of your classic when people think of AMC or arthrogryposis. This is what they're typically thinking of. It's idiopathic, means that there's no genetic cause, absent joint creases, waxy skin. You've heard all this before, so I think I'm going to skip over some of this. But just to show, generally speaking, children with amyoplasia have their shoulders, and this is of the upper extremity in particular. The shoulders are typically adducted, which means they're on the body, and they're internally rotated, which means that their hands are facing out. The elbows can have flexion contractures if they have weak triceps, and that means the elbows are bent. Or more commonly, they have extension contractures, which means the elbows are stuck straight. And that's the most common with amyoplasia. Sometimes you have both, where you have weak biceps and triceps, and you end up with an arm that's somewhere in the middle. Forearms typically tend to be in neutral, which means that they're not too far this way or too far that way. They're usually right about in the middle. Although some kids are in supination and some kids are in pronation, and that can vary. Wrists tend to be in neutral, also in deep flexion. So interestingly, the less muscle kids have, the more likely they are to be in a neutral position, and the more muscle they have, they tend to be in more flexion. And then it turns around as you get more towards even more muscle, then it starts to turn the other way, and they tend to get more wrist and extension. Thumbs tend to be in the palm, and the fingers are usually stiff. With the MP joint, and that's this joint here, being the most mobile. And sometimes you'll see kids having the sort of the queen wave. There are also these distal arthrogryposes, and these look very different than amyoplasia. It's interesting that everything's sort of been lumped together because they all have joint contractures, but from a treatment standpoint and from a functional standpoint, they can look very, very different. There are quite a few distinct autosomal dominant disorders, which are the distal arthrogryposes. This is a list of them. It's not that important for you to know. From a distal arthrogryposis standpoint, the shoulders tend to be spared, and they're usually minimally affected, if at all. The elbows can be flexed as in Escobar syndrome, but most of the time the elbows are quite mobile, both in flexion and extension. And flexion is bending the elbow, extension is straightening the elbow. The forearms are usually in a good position, and they have some rotation as well. And the wrists are often, unlike amyoplasia, which tends to go into flexion, the wrists tend to be in extension. The thumbs, unlike being in the palm like this, the thumbs tend to be bent at this joint, which is different. And fingers and the MP joints tend to be in flexion and ulnar deviation. The fingers can be wind blown like this. That's the description. And the finger IP joint, which is these fingers here in the finger itself, can sometimes be bent in what's called camptodactyly or bent finger, especially the long and ring fingers. Some common distal arthrogryposis types are the Freeman-Sheldon, or known as whistling face syndrome, Beal syndrome, which has the crinkly ears, and contractural arachnodactyly. And this can look just like Marfan syndrome. You have Escobar syndrome like this with pterygia in the elbows and the knees. And then there's another 300 kinds or so just to throw into the group. So in terms of the upper extremity, really what we are looking to do is improve not only from a lower extremity ambulation, but also upper extremity can contribute to ambulation as well. It can help a child to get up from a seated position. It can help a child to scoot. Somebody's playing music. There's self-feeding is really important. So you want to be able to get the elbow to the hand to the face. Really, if you think about it, imagine it like a crane. The working part is your hand. The rest of the function of the arm is to get your hand where it can do the most good, where it can function the best. And so self-feeding is really important. Perineal care, being able to wipe yourself, is really important. Self-care, and such as getting dressed. And Mary Beth Izaki, who taught me most of what I know about arthrogryposis, other than what Scott Cozen taught me and Harold taught me as well, was one hand to eat and one hand to wipe. And it can be the same hand, but you have to be aware of bilateral procedures, meaning if you end up bending both elbows and there's no elbow that goes straight, then you have taken away the child's ability to wipe. And so sometimes the best thing is to have one hand to be able to eat and one hand to be able to wipe. And it can be the same hand, which is fine, but just be careful of doing both sides at once before you really know what the outcome is going to be. So I'm going to go through the treatment options from shoulder to fingertips of all the different joints as highlighted there. So first off, I just want to say, because I get a lot of questions about this from a lot of parents, I'm sure you do too, Harold, is muscle transplantation. I would give my child my muscles. Can I give them my muscles, right? And the answer is that's not really an option. And there's a couple of reasons for that. One is it requires a donor muscle from a matched volunteer. That usually can be a parent, right? But it requires functioning nerve as well in the child to be able to power the muscle. Because think about it like an appliance. You can take a fan and take it from one room to the other, but if there's no outlet in that second room, that fan is not going to work. And so you need both the muscle and the nerve working. And that's a challenge for children with arthrogryposis, particularly amyoplasia. And also the most important reason is it requires immunosuppressant medication, meaning you have to use medications that reduce and weaken the immune system. And that gives you a risk that decreases the risk of rejection, meaning your body fights that muscle that was put in, but it also gives you cancer and it also risks severe infections. So this is not an option. And then I also get a lot of questions about stem cells, right? Can we just inject some stem cells somewhere? And what I tell patients and families is stem cells are like bricks, right? A brick does not make a house. There's a lot, a brick is not equal to a house. It takes a lot to get bricks to become a house. And so, yes, stem cells of muscle, you can put them in somewhere, but you need to get them, again, you need to plug them into a nerve. You need to get that nerve connected to the brain. You need to get the muscles in the right orientation to do the right thing. You need to get the joints to move. And so there is currently no credible stem cell program. So initial treatment for children with arthrogryposis is always stretching, especially in the younger children. 80% of kids with amyoplasia, for example, will get therapy into their teenage years. Splinting is really important. It's often difficult to do at a young age because you can't even get the splints on their little fingers or their little hands. Nighttime only to encourage use during the day. I'm a big stickler in trying to get the child to use those hands and develop whatever musculature they can, because as we all know, children with arthrogryposis tend to improve with age. And part of that is they are developing their musculature. And that's really important, and we don't want to get in the way of that. Serial casting, generally better for distal arthrogryposis, but certainly can be done. The uses in the upper extremity are pretty limited. So let's start specifically with the shoulder. So the shoulder is, I think, the most difficult from our standpoint as clinicians, because there's not much that we can do. There's currently no surgical procedure that reliably gains shoulder function, such as abduction or for overhead activities. And that's something that I get asked about a lot. There are two devices currently available, the magic arms and the play skin, which can be helpful, particularly if the child has the ability to pull the arms down. Then the device can help put their arms up. And so they'll rest with their arms up, but they can pull them down. And for some children, that's very functional. For the majority of children, either it doesn't apply or it doesn't help them. So the other problem, as I mentioned, is that children tend to have their shoulders internally rotated, as you see in this child. Early stretching or external rotation can help minimize or correct the contraction. As the elbow is straight, right? You can imagine it's very difficult to tell where the shoulder is, because you don't know if the rotation is coming from the forearm or the rotation is coming from the shoulder. So we have a lot of difficulty before we bend an elbow, if the elbow is straight, telling where the shoulder is. So for internal rotation shoulder contractures, the only real option at this point is external rotation osteotomy, or HRO. And the timing is really anytime after the first birthday. There are no options currently to increase the strength or the motion of the shoulder, as I said. Humeral rotation osteotomy has a tremendous number of advantages and some disadvantages. The indications in general are for children who have internal rotation contractures that limit the ability of the hands to reach each other. If you take a child that hands face away from each other, and the hands are facing, and the thumb is facing away from your eyes, you cannot see your hand. You can try this on yourself, and it's very difficult for you to function. If I just turn the hands like this so that you can see your thumbs, it's so much easier to do things with your hands because you can now see what's going on. And especially this crossover grasp is a big problem, because it's not how, again, you cannot see what you're doing. It's away from your eyes. So the indications generally, as I said, are just having that internal rotation contracture. The contraindications are that you don't have any internal rotation to spare, meaning the position you're in, your shoulder is quite stuck, and you need that position to be able to reach through your legs to be able to wipe yourself. You cannot take away the child's ability to wipe. That is a tragedy, and I've seen that happen. So sometimes you end up doing one on one side and one on the other side. Again, one hand to eat, one hand to wipe. Ideally, you can do both with both, but not necessarily always. So from a surgery standpoint, there's a lot of different incision options and it depends on who you see. They'll do an incision at the end of, down by the elbow or up by the shoulder. They'll use one plate, pins, screws. There's a ton of different options. I can talk about the details of what I do now, but one of the big problems that we have is if you imagine children with amyoplasia in particular, very thin bones, right? And they fall a lot, and that's a bad combination. And so I would say that about 10% of the kids that we do this operation on end up breaking their bones, and usually just above the plate. Now, would they have broken their bones anyway? I don't know, because it's still very common. I have a child I just got an email about that broke his humerus, and he's coming in on Friday. So it does, and he has no plate. So it still does happen even if you don't fix it, but I think the risk goes up a little bit if you have a piece of metal. The other thing that we've done over the last few years is adding a little bit of rotation to the cut so that we can both correct for this, but also angle the elbow so that if you're maybe 10 degrees or 15 degrees or 30 degrees shy of being able to reach your mouth, we can do the osteotomy at the end of the bone, bend the bone, and now you can reach. The same thing, we can also straighten the elbow in the same manner. So from a post-operative standpoint, just soft dressings, long-term concerns, as I said, are fracture and also recurrence. I've seen kids who we fixed them, we love where they were, and then over the years they come back. Again, the improvements are hand-to-mouth, improved hand-to-hand function rather than crossover, and the results are quite predictable, even though the recurrence does happen. Elbow extension contracture is another very common thing. This is probably my most common operation that I do, is trying to do something to bend the elbow, and also one of the most useful operations that we do. Early stretching can certainly help minimize or correct the contracture. However, if the elbow has less than 30 degrees of flexion, it's very difficult to tell where the elbow is. And I've seen some really well-intentioned moms and dads and therapists bend the elbow in the wrong direction. And that's a huge problem because that pulls the ligaments apart and that destabilizes the elbow. That makes our job much harder later. So generally speaking, I do not recommend any stretching in a child where the elbow is stuck nearly straight because you don't know where that elbow is. Zero casting and splinting, really only if greater than 45 degrees of flexion. All right, so the most common procedure that we do, as I said, is elbow release and triceps lengthening. And we have good data to show that the best time to do it is between 1 and 2 years of age. This is the data. So when we looked at our kids, and we were doing it as young as we could, but patients don't reach us until they're sometimes much older, either because they're adopted at an older age or because they've been told by other doctors there's nothing that can be done, and somehow they find us and then they come to us, and by that time, they're 5 or 6 years old, and it's much, much harder. But we did it anyways, and you can see the results are not as good if you get a child later. If you look at less than 2 years of age, they started out here. They started out with only 16-degree arc of motion. That's the green. This is the total arc of a regular elbow. And this was after the release with at least a 1-year follow-up. And you can see they almost gained 90 degrees of elbow motion, which is phenomenal. And those are in kids less than 2 years of age. By the time you get to kids older than 3 years of age, they only improve by about 10 degrees arc of motion compared to what they had before, but in a better orientation. But you can see they lose more extension. So the results are not quite as good, and they're not as predictable. So indications: insufficient elbow flexion to feed, so the ability to reach the mouth. But we never do this operation bilaterally, and I would caution any of the parents out there who are being told, yeah, let's get it done both at the same time. And the reason is, if both elbows get stuck in flexion, which I have seen, there's no way for the child to wipe themselves, and that's a tragedy, especially in a child who could have. So contraindications: no elbow extension to spare, right? So you need the elbow extension, for example, for wiping, and the contralateral elbow, which means the other side, has insufficient extension to wipe. And so if we do one elbow release and we get the ability for feeding and wiping, then I know that the other elbow is now in play. And then I can operate on that without worry that I'm going to sacrifice the child's function in some way. All right. So I'm not going to go into the surgical details too much, but just to say that we do move the ulnar nerve, which is one of the major nerves of the arm. And the reason to do that is because if we don't do that, the nerve will stop functioning. We also lengthen the triceps, and we release the capsule at the back of the joint. From a post-operative care standpoint, and by the way, there's a lot of this information is on our website, and I put a link to that at the end of my talk. So from a Right, so it's a splint or a cast for about 2 weeks. I had one mom recently who talked me into moving the elbow at 1 week and had great results, but we've been having some wound issues. So I think I'm sticking with 2 weeks for now. It'd be interesting if we had a forum with other physicians who are doing this operation on a regular basis, what they're doing now. Removal brace for about a month all day, and then 2 months at night. And then long-term concerns, you can lose elbow extension, as I said, which means the ability to straighten the elbow. You can weaken the triceps permanently from this operation, particularly if the triceps is not very good. And it can certainly recur. So this requires some vigilance in the long term, right? Results are quite good, as I showed you, right? Elbow flexion contractures, that's the only child I didn't blank out. Apologies. But I'm sure they wouldn't mind. So early stretching can minimize or correct the contractures for elbow flexion, and that's your Escobar syndrome. But there's no really good answer for this. So now let's talk about, so we've gained passive elbow flexion, which means a caretaker can do it, or they can do it against the desk or against their knee or against the other arm like this. But how do we get that elbow to bend with the child's own power? And there have been a bunch of different options, which I've listed here, and I'll go through those. Our favorite option by far is the bipolar latissimus dorsi muscle transfer. I just saw a child today that we did many years ago. She's spectacular. I mean, and I asked her, what's her favorite? We've done carpal wedges on her. We've straightened her wrist. We've done thumb. We've done tendon transfers. We've done all kinds of things. And I asked her today, what's your favorite thing that we've done for you? And this was the operation that she said was her favorite. And why? Because now you can grab something off a table and put it in your mouth. And her function has been phenomenal. Her results are great, but that's not across the board for 2 reasons. One, not everyone has a really good latissimus, and that makes it difficult. Also, not everyone has a great triceps. So the operation is a big operation. This is not a minimally invasive surgery. You release the latissimus from its origin and from its insertion. You can tell from this picture that it's well attached. So it takes a lot of effort to do. It's a 3.5 to 4 hour operation, and it works really well. Here's an example of how we examine the latissimus, and you can see it there. Me pointing it out, that's the latissimus. If you see that, we know that the child has it, right? This is the results of a study we published recently, and I'll tell you the results are quite good. You can see the postoperative range of motion is somewhere between 30 and 120 degrees or so, which is great. And the strength is also quite good. Here's the child that we had done latissimus on. And you can see, and I think she was coming in for the other side. I can't remember. Oh no, we had just done the other side. But you can see she's bending her elbow, and she couldn't do that before. And that's a wonderful thing. So apologies for the sound. So lower pectoralis major muscle transfer is one that I've talked about with this group before. And I would say that it is an operation that has not been as good, either in my hands or in anybody else's. It is an option. And I think if your pectoralis is a really good muscle, you have that option. We've done a few now, and they've done okay, not great. And so I'm not sure that I'm going to keep pursuing this operation. I think if it's the only option, then we'll consider it. But I think it's one of those operations that I actually traveled to Russia to learn how to do this. And the results were good, not great. Okay. But I think worth having as an option. The free gracilis muscle transfer is an operation that we do quite a bit for other diagnoses, but I've yet to do it on a child with arthrogryposis because I have not yet found this muscle in a child with arthrogryposis. But that is certainly another option, and something that you should probably discuss with your surgeon if there are no other viable muscles in the arm, and especially if the legs are normal. The child has to have effectively normal legs. Long head of the triceps transfer. My mentor, Mary Beth Izaki and Scott Oishi, are really champion in this, as is my friend Gloria Gagola. And We've not had great experience with this. I would say that if this is something that you're interested in, that you've heard about, that you visit any of these guys in Texas to have that operation. The full triceps transfer is an operation that's now been discredited, which means taking the entire triceps. I continue to see this from time to time, which is very sad. It just means people have not read anything for the last 20 years. Forearm contractures. Generally speaking, as I said, most patients are in neutral position. Pronation and supination contractures, which is stuck here or stuck here, are about equally common. Pronation is really useful. That's hands down. It's required for going through the legs to wipe. It's also very helpful for iPads and keyboarding. Supination is when your palm is up. That's required for behind the back wiping, and it's also helpful for eating. Early stretching can help minimize or correct the contractures. There's currently no really reliable surgical option for improving the arc of motion of the forearm. The only operation that we do currently is what's called a one-bone forearm, which is where we take whatever position we think is the optimal position and we put the child permanently in that position. And that's been great for the kids, but it's a very select number of children who would really benefit from that. Again, indications of a one bone forearm, the child is stuck in too much supination or too much pronation, but just be careful of bilateral surgeries. Be careful of submitting your child to anything that is two operations at the same time on the same segment of the body. For the arms. For the legs, it's a little bit different because everything has to have symmetry. For the arms, sometimes you want one to do one thing and one to do the other. You don't want that when you're walking. So contraindications, no limitations in their activities. So if they're doing really well, there's no reason to operate, obviously. And if they have better than 60 degrees of active forearm motion, generally we try to not do this. This is the basic surgical details. Here's a child who is stuck completely the other way around. And this is what the x-rays look like. And you can see in this example, we've turned this child from full supination to a nice pronation, which not only has functional improvement, but has aesthetic improvements as well. Wrist contractures, very common, particularly in amyoplasia. This is due to fibrotic or shortened forearm muscles. Interestingly, if they don't have any muscles, then the wrist goes into about a neutral position. But if they have some muscles, it's usually a little bit here and a little bit in the back, and the flexors tend to win. They tend to have absent wrist extensors, and they can have these carpal coalitions, which means the bones stick together in the wrist. Now, there are some surgeons who believe at a very young age to do a carpal wedge osteotomy to bring the wrist into extension as a sort of a mandate. And I hear this a lot from parents. I hear it a lot from parents that they want their child's wrist in extension. There are good reasons to put a child's wrist in extension, and there are many good reasons not to. And this is, I think, the meat of this segment. So from a wrist extension standpoint, wrist extension, which is this, is really good for appearance. It's good for improving grasp. And it's, however, it weakens your ability to open your fingers. You can try this at home. Put your wrist all the way down and open your fingers. It's very easy. Bring your wrist all the way up and try to open your fingers. It's very hard, right? Now, you imagine if you have a child with amyoplasia or any of the other arthrogryposes who has difficulty with their finger motion, and this is going to make it even harder. So wrist flexion has a value too, because it allows you to release things, right? Allows you to open your fingers so you can take things out of your hand. And you may need it, wrist flexion. If you're wiping through the legs, you're going to need wrist flexion to reach all the way around. You may need wrist flexion for eating. So let's say my elbow only goes to 90 degrees and I have a stiff neck. Maybe I need wrist flexion to get my fingers into my mouth. Maybe I need wrist flexion for scooting. Maybe I use the back of my wrist to weight bear. And so that's how I move around a room or around my bed, right? So wrist flexion has value also, and don't discount that. So wrist flexion contracture, children with wrist flexion contractures, Early stretching can help minimize or correct the contraction. And as I said, children with amyoplasia in particular, but all children with arthrogryposis for the most part tend to get better with age. Serial casting and splinting, I tried for a long time and that was very disappointing. And I would say it's only for correction of mild deformities, usually followed by tendon transfers. You can usually get somewhere if you don't do a surgery at the end of it to keep what you've got through tendon transfers, then it'll go right back. It's not like the legs where you can get the legs in a certain position and then you're reinforcing that position by weight bearing on it. This is just floating out in space and it'll go back. So carpal wedge osteotomy is the mainstay of treatment for us and for the majority of surgeons that take care of children with amyoplasia or arthrogryposis. Timing is really any time after the first birthday, but I think there are there are a few indications and there are many contraindications to do this operation, as I alluded to earlier. The indications or the reasons to do it are the wrist is stuck in flexion. And again, I caution against bilateral procedures. The only bilateral procedures I will do on a regular basis are humeral rotational osteotomies because I want those together, right? I'm planning on doing those together to get the hands to meet in the middle. But if you're going to extend one wrist and then extend the other, and now the child needs to wipe through the legs, you've taken away their ability to wipe. And as I said, that's a tragedy. So you need wrist flexion to reach your mouth, then you can't bring the wrist into extension. You need wrist flexion to wipe, you can't do this operation. You don't have good finger opening, you can't do this operation. And then if you're putting weight on the back of your wrist and that's how you get around, no matter how well that operation is done, you will weight bear on it until you undo the operation. And that's not going to work. Here's some of the technical details of the operation. It's basically just cutting a wedge out of the bones in the wrist. It sounds pretty barbaric, but it's actually very well tolerated. It's not a hugely painful operation compared to a lot of things that we do for and to these children, as we know, right? We fix the bones. I used to use pins. I have not used pins in 10 years, and I have never had it not heal. And I got to knock on something, right? But yeah, so far it's been great. I don't like pins. A lot of people use pins. I'm going to try to convince as many people as I can to go away from it. And then you have to move one of the tendons from the side of the wrist, which is this side of the wrist, over to the back. And that tendon is usually working, but not always. If that tendon is in good condition and that muscle is good, the results are better. So after surgery, it's splinter cast for 4 or 5 weeks, removable brace for another month after that, and long-term loss of wrist flexion and recurrence can happen. So you can certainly make the wrist stiffer with this operation. And we just looked at our data. We lost about 15 degrees on average per patient on wrist motion total, but we got them into a much better position. So I think overall it's been a win. Here's an example of a child that had a carpal wedge on this side, but not on this side. And you can see the difference. 45-degree correction is typical. It improves grip strength. It improves cosmesis, and it's predictable, generally speaking. Recurrence is common. And so I encourage all of my patients, unless I forgot to tell you, but I encourage all of my patients to splint pretty much until they're done growing, just with nighttime splinting. So I'm not going to get into our recent data in the interest of time. Thumb and palm deformity is very common. This is a child, but they're different thumbs in different types of arthrogryposis. This is a child with Freeman Sheldon, and you can see they have the typical clasp thumb, which means the thumb is bent at this joint, but not here. This is a child with amyoplasia that has flexion here, bent thumb here, and bent here. And that's more difficult to treat. This is a child who just has bend here primarily. So they're all different. As I said, many different thumb types depending on not only the condition, but also on the child itself. And there are many different things to take into account. Each different joint needs to be assessed independently and as a whole. And also you want to look at their function, what's happening with their muscles. So for thumb flexion contractures, and that's when the thumb is stuck in the palm, early stretching, as always, serial casting can really help, particularly with distal arthrogryposis. For children with distal arthrogryposis, the typical thing is that this joint here at the thumb, this joint here is bent down, right? And you want to take that, that joint and bring it up. And then we move some skin around to open up the web space. I'll show you what that looks like. So this is an example. And by the way, all the videos on these procedures and outcomes, they're all on our website, Little Arms. So indications are clasp thumb. Bilateral is fine because you're not dependent on the outcome of one to determine the procedure on the other. Contraindications, no thumb motion, inadequate finger flexion for pinch. So this is our Stiletto Flap. I think it was actually Mary Beth Izaki and Scott Oishi who developed this flap. It may have been Peter Carter. I don't remember actually. I'm sure they would know. But it's a great flap. It's a wonderful design. It's a huge contribution that they have made for children with arthrogryposis. And I would say almost every other patient that I see in the office is either going to have this or has had this operation. And so again, kudos to the guys at Scottish Rite for devising this. It's brilliant, and has helped a lot of kids. So after surgery, again, splint to cast for 4 or 5 weeks. And this is an example of what you get. You start with the one on the left and you end up with the one on the right. And that's a huge difference in both the appearance and the function of the hand. If the thumb gets in the way, it's great to get it out of the way and somewhere we can do some good. It's different from your typical amyoplasia hand, which looks more like this. For those children, we do an operation that we developed. And one of the nice things of being at Shriners is that we have a tremendous amount of leeway in developing operations and traveling to places and learning. As I said, I've traveled extensively, as has Harold, learning from other people. We've developed a lot of operations ourselves. So I think it's a huge gift of having the kind of independence that we have at the Shrine. But this is one of those operations that we developed ourselves, and I think has been a tremendous benefit for our patients. And I think we're one of the few places that does it so far, but I'm not sure why people haven't taken it up. I'm not going to go over the details, but it's basically the difference between a fusion, which is sticking this joint, versus this operation is that we actually bend the bone by cutting it here and pull it out of the palm and also rotate it so that it's more in a position for grasp and pinch. And you can see the results here. His right thumb has not been done. The left side has been done. He eventually asked us to have the other side done as well. And the pinch is improved, grip is improved, and cosmesis is improved. And here's a video of a child that we did. And you can see her pinch and grasp is fantastic. And I think we did her other side too. Yeah, I think for us, the greatest measure of success is when a child says, do an operation on me, please. And this is one of those operations. So for finger flexion contractures, in the interest of time, I'm going to go quickly. Known as camptodactyly is when the fingers are bent. There's a fairly simple operation where you just rearrange some skin called the Z-plasty, and we cut one of the tendons of the 2 tendons to the finger, and we tried to lengthen the finger as much as we can. Camptodactyly release, or releasing bent fingers, is actually has very variable results. And it's something that we still do because I saw a girl today, unbelievable, fantastic results. I couldn't even tell that she had bent fingers ever. But the majority of kids are not like that. And I would say it's a 50-50 of the kids that you make. You get everybody better to some degree, but you know, I think it's still, I'd love to have a better option. Here's an example after the surgery. And as I said, the results are unpredictable. So my 2 cents is that there's a thin margin for error in children who are kind of on the border of function and not function, particularly because you have to account for all the things that we need to do on a daily basis to get through our day. And if you give somebody the ability to feed themselves better, but take away their ability to wipe, that's bad. And the vice versa also. And so you need to balance, and you need to think about your child incorporating all the activities of daily living, getting dressed, brushing their teeth, combing their hair, using an iPad, using a computer, et cetera. All the things that we need to in modern day to get through our day, all of those things need to be accounted for when you develop a surgical plan. And we spend a lot of time on this, and kudos to our therapists for their help. Beware of too much at once for that reason. Beware of bilateral procedures for that reason. And then, you know, many of you live in places where you're the only family that has a child with arthrogryposis. And it sort of comes to you to trust, but also to educate your therapist, right? And to learn from other parents, and also to educate yourself. So I'll leave it at that. And this is our website. If you go to www.littlearms.org, you go under Little Arms University, there's the arthrogryposis section that'll take you to all the surgical videos that we've done over the years. And I think it's a really helpful resource, both for physicians and for patients. And there's some of the talks. So thank you so much. I'm going to stop my screen sharing and we'll do some questions.
And that was a great talk. Thank you very much. I think you exemplify one of the reasons why it's so much fun to work at the Shrine, because I have people such as you who are so creative, coming up with new ideas with problems that you see. And on top of that, also being able to collaborate. That you spoke a lot about the other people who do work in arthrogryposis handwork. And it's clear that you're all together working on these things with each other and coming up with new ideas. And not surprisingly, there are a lot of great questions out there for you. So let's see if we can get right to them here. Some of these are general questions. Let's see how comfortable you are. This is the first one here. If there are no genetic markers for amyoplasia, how can you get a definitive diagnosis? We're stuck between distal and amyoplasia, and no one could confirm which one it is. What should we do?
Yeah, so usually they look very different. So the question is, why is that even important, right? So why do we care whether you have distal arthrogryposis or amyoplasia? And in terms of that child, probably not a huge difference. So we're going to treat the contractures regardless of the cause. And we're going to look globally at the child no matter what the cause. And so it doesn't really matter from the standpoint of treating that child. Where it's relevant is if you're thinking about having other children and whether or not there's a genetic component, right? And if the child has usually they're autosomal dominant, which means that one of the parents either had to have a copy of the gene and therefore has the condition as well, or there was a primary mutation, meaning the child is the first of that line, right? And so it makes a little bit of difference in terms of how you maybe family plan, but it's more important for the family planning of your child. Or if you're the person with arthrogryposis, it's certainly how you family plan. But I'm not sure that it has too much practical relevance. And I would say that the vast majority of times, the distal arthrogryposes are pretty discernible from amyoplasia, and it's hard to confuse the two, although we've done it.
Yep, we sure all have. All right, next one. Our AMC's contractures seem to be worsening as she ages into teen years. Should we look into splints again?
Yes. So typically that's unlikely unless something has been done. So if the child has the natural history of amyoplasia or arthrogryposis in general is for the child to improve throughout their childhood. The one caveat to that is if you do something to like change the curve where you've improved upon that child's function, they have a tendency to go back to their natural curve. So yes, their natural curve was to improve slightly and you did this. So now they're up here. There's a tendency for them to return back to where they would have been before you did something. So it's unlikely that they worsen from a natural course.
And so a quick word about splints, daytime, nighttime, both. What's your thought on that?
I think, as I said, my preference is only nighttime. except for right after surgery. And the reason for that is I want the child to develop as much musculature as possible. So I want them to use their hands as much as possible.
Okay, next question. Can you move muscles from the child's own body to other parts of their body? Meaning, can you do a muscle transfer?
Yes. So the latissimus, which I showed, is a muscle transfer, and we do that on a regular basis. That's a great operation. The nice thing about the latissimus, it brings with it its own plumbing, and it brings with it its own electrical. So it has its own nerve that we move with the muscle. Those are the best operations for children with arthrogryposis. The other operation, which you take a muscle from the leg, which is the free Gracilis transfer, there are case reports and there are small series in the literature of people who have done maybe 3 or 4 of these operations. But generally speaking, I have yet to find, we see, I think at the Shrine, we probably see the largest volume of arthrogryposis kids in the country. And I have yet to meet a child who had a Gracilis. And we've done quite a few MRIs to look for it, and you can see it missing. It's very frustrating.
So explain real quickly what a Gracilis muscle transfer is.
Okay, so Gracilis is a muscle from the leg that all it does is it helps bring your legs together, but there are 3 other muscles that do that. Am I right, Harold? I don't know how many muscles. There are several other muscles. Plenty other, right. And so you can take that muscle, it's the weakest of them, but a weak muscle in the leg is a really good muscle in the arm. And so you can take that muscle out of the leg. Unfortunately, you have to find plumbing, and so you have to connect it to new blood vessels, which makes it a much more complicated operation. And you have to connect it to the electrical. So you need some nerve that's working that you're willing to sacrifice, right? For the most part, when we do this, we take a nerve from the back here, or we take a nerve from the chest. We take the rib nerves onto as the electrical supply. Those are hard to find in children with amyoplasia in particular. Yeah. So, yeah, go ahead, Harold.
I was just going to say what's fun is that I'm watching Jean kind of pushing questions around while we're talking. She tries to put light questions by light questions. And so someone said, no, wait a second. I thought you said you couldn't transplant muscles, but that just rounds out the talk here. So you're talking about taking your own muscle from one place to another. And before you're talking about taking somebody else's muscle and putting it to the child. That was the most concerning way. That really has very little to offer.
Yeah, I mean, obviously we'd all love to do that. And I think if we could give muscles to children with amyoplasia, I think Harold and I would have very few muscles left.
All right. So real quick question. Do you remember what was the splint that was white with blue Velcro? Somebody just thought it might be great for their child. And I can't remember which one that was.
So that wasn't, yeah, that was I think that was an anterior posterior splint. So one of our therapists came up with that actually. Where the splint goes here and here. Yeah, yeah. If you reach out to us, I can have our therapist contact your therapist, and we can show them how to do it. So that's easy.
And what does that splint do? What are you trying to do with that splint?
It bends the elbow. Yep.
Okay. Our AMCer age 3 tends to lay when playing on the ground and lets gravity do the work to move his arms. It seems as though he is avoiding the work to build muscles. Should we stop him from doing this or try to promote stop him from doing this to try to promote muscle development? No, I think you let the child, we love cheaters in this game. Cheat at the best way you can. In some ways, what makes the children with arthrogryposis so functional is not only the will and the parental support and the family support they get, but also the fact that they cheat like crazy, and we love it. So let them find their way, however it is that they can do it. If it improves their function, by all means. Yep. All right. If they have muscles to develop, they'll develop them. So a few rapid fire questions. How young would you do surgery on an AMCer? Is it too early if they're younger than a year old? Is it better to wait until they're older? But that, of course, depends upon what you're talking about.
So yes, it depends on what you're talking about. So, right, yeah, I have not been bold enough, I would say, to operate on children less than a year of age. And I don't think that that has hurt us in terms of our outcomes. Olga Agranovich, who does probably more, she's probably the only person that does more upper extremity arthrogryposis than I do. She operates on kids at around a year. I think she does some earlier, but I don't think that the results are worth taking the extra risk, because the child's at risk under a year of age, more so than they are after. So my concern is really primarily anesthesia.
So if you think about the different procedures you do, what procedure would you do at 1 year? What procedure would you do at 2 years? What would you do at 3 years? If you're looking at a child and trying to build an itinerary for a family.
Right. So the most important thing is to bend a straight elbow. That's the one thing that we know is better at a young age. Everything else that we do, every other operation that we do, except for maybe the camptodactyly, which is the bent fingers, every operation has no time clock. And the results are either as good at a later age or better at a later age. When we do the thumb operations are better later than they are at a young age, generally speaking. And so for us, what we do typically is, and it's actually, if you think about it, if I take your elbow and I bend it, but your shoulder is internally rotated, you're going to drive your hand into your chest. If I externally rotate you, you're going to put your hand to your mouth. And so very often we will do, our typical protocol now is if the child has both internal rotation, shoulder contractures, and extension contractures at the elbow, then I'll have Scott Cozen, my partner, do a humeral rotational osteotomy on the one arm while I do an elbow release, and then we flip. And 3 months later, we'll come back, or 6 months later, we'll come back and do the opposite. And the goal for us is to get both elbows bent by the time they're 2 years of age, because the results are better. Yeah. And humeral osteotomies make the, actually help to preserve and optimize your elbow bending.
All right, so here's fun. We have about 8 minutes left, and we've got a lot of questions. So we're going to go rapid fire. So real quickly, question about,
this is the bonus round.
Do you operate? Yeah, do you operate on preteens? Is there cutoff for surgery? And somebody else said, I'm 19 years old. Is a thumb operation still an option for me?
Thumb operation's great at 19.
Good. So no cutoff for surgery. Do you do surgery on non-dominant arms? Why or not? Why or why not?
Yes, preferably.
Great.
Because it's a bonus arm.
Let's see. A couple of more administrative questions. People are coming, families coming out to see us, you and I, and they're wondering if they can get OT and PT while they're there so they have something to share with their home therapists.
Yes.
What is your wait time for new appointments?
Next week.
Okay. Oh, let's see. Would you be concerned to see an
AMC? Maybe not, but close. Yeah.
A few weeks, yeah. Would you be concerned to see an AMC using fingers and unusual contractures as their dominant fingers on phones, tablets, and for typing? My AMC has a middle finger stuck in an unusual curved position, which causes it to stick out against the screen. Therefore, he uses it in place of a pointer finger, but it seems like it's not a great way for him to do this in the long term. Any thoughts?
If it works, stick with it. If it's problematic, we can change it.
Yeah, and then also always worth having it evaluated, because maybe there's something that could be fixed that will work better. Let's see, do you ever come out to other hospitals to treat AMCers, or is Philadelphia the only place?
Philadelphia, New York City, and Greenville, South Carolina.
We just had our AMCer 4 weeks ago. This is overwhelming. How can we know what procedures we should be looking into? Is there a guide or an explanation? There are so many medical terms and I can't keep track of them. It feels like our doctors are speaking in another language. And I'll add to that, is there any urgency?
4 weeks, no urgency. I will also say that they are speaking in another language. And I will also say that our website hopefully will give you a lot of information. And if there's anything that you still have questions about after reading the website and watching the videos, you can always reach out to us.
Absolutely. Do you talk with OT and PT for a patient before deciding on surgery?
Yes.
I'm really struggling deciding on whether to do the FCU, the flexor carpi ulnaris to the extensor carpi radialis brevis without the wedge, or to add the wedge. It seems some research and between patient outcomes that the wedge can reduce function and flexion. Have you seen any child have the transfer and not have the wedge?
Yes. So, well, that's actually a very loaded question. So FCU to ECRB is not an operation that is done in children with arthrogryposis. So I don't know where you have this suggested to you, but that is a muscle that is the most affected, particularly if your child has amyoplasia. That is the most affected forearm muscle and the least likely to work. So somebody suggesting an FCU to ECRB transfer makes me very suspicious. They are more used to treating cerebral palsy than they are in treating amyoplasia. And as I said, I treat a lot of kids with amyoplasia. I have never done that operation. I have never seen that muscle be worthy of transfer. So if you do that transfer, you can end up with a wrist like this.
Do you have experience with Larsen syndrome? My son has dislocated elbows and he is unable to straighten them due to one of the bones getting in the way. So I'm unsure whether we should do anything for them or leave them alone. Can we email you an x-ray?
Yes, please. Yeah, the radial head dislocation can be an issue. Sometimes you're better off leaving it because it gives you some elbow stability. Sometimes it's better to remove it because it limits motion. So it's complicated and it's case by case.
And it's age related too, isn't it, to a certain extent?
To a certain extent, although I think, yeah, certainly the younger you do it, the better, if you're going to do it. If you're not going to do it, age doesn't matter.
All right, here's a tough non-clinical question. When will you be coming back to Greenville?
Ooh, that is not up to me.
Okay. My daughter has, go ahead.
No,
Yeah.
I'm saying I miss the place. It's a wonderful place to visit. So I feel like I've lost my family down there. But yeah, anyways, go on.
My daughter has Escobar syndrome, shoulders rotated in. Her therapist and previous doctors have done no casting on her arms, no surgeries. She is 10. Her arms hang and have no control over elbows, wrists, fingers. Do muscles wither away over time, or is there hope of still getting some functionality out of her arms?
Yeah, so muscles don't really wither away over time unless you have a progressive degenerative muscular disorder of some kind. They generally improve over time. So you'll make more muscle over time. The fact that your child didn't have therapy or casting or surgery is not going to impact their ability to form musculature. If their musculature didn't form, it's because they didn't have musculature to begin with. All you need is basically, it's like an acorn and an oak. You just need one seed and you can grow a tree. You need a few muscle cells to make a muscle because they can multiply. But if you don't have that to begin with, then obviously you can't do it. So yeah, okay, go on.
If our 11-year-old's right wrist is more in neutral, 45 degrees extension from neutral, and maybe only 25 degrees of flexion, should we stop our night splinting this wrist in neutral and extension? Okay, let me try that again. So her wrist is from 45 degrees of extension to maybe 25 degrees of flexion. And they're wondering if they should stop splinting it in neutral or extension if she doesn't have that much flexion.
Yeah, I mean, I think you can do a trial. That's what I would recommend my patients. If the wrist has been stable for a while and it looks good and you think that you want more flexion, if you want more flexion, then certainly let it go. If you are happy with the extension and you want to keep it, but you feel like maybe we'll give her a holiday, then do that. There's no harm in trying. You can always, if you had it, you can get it back with a cast.
And this person asks, they've been told that the more surgery an AMCR has, the higher the risk is for becoming stiff. Is this true?
No, I don't. I think beware of generalizations. That's what I say.
All right. I
Generally speaking, I say beware of generalizations.
I generally agree. It's a major disappointment. I have no idea where to start with doctors as a young adult of 19 years with distal arthrogryposis. Anyone to recommend or specialty type of doctor? I don't think I can go to Shriners anymore, sadly, since of my age.
So if you're 19, there's no other option for you. I think Shriners would make an exception. I can sort of see you offhand in New York because I can get you through the clinic there, and age is not so much of a factor. So if you're near New York City and you want to be seen, that's certainly an option.
All right. Now this person's maybe a little too old for a Shrine. I'm 58. At 5, I had something that put left bend in arm. Bought me years of independence. At age 54, a freak accident undid that surgery. My arm went straight. It was alien-like. But surgeon used muscle still has no bend. So it sounds like they had an operation done at 5 to get the elbow to bend better. Then there was an accident 4 years ago. And since that time, the arm is straight. They tried to do some work, but they can't get it to bend. So why would that be? That's a hard one to see without examining the patient.
Yeah, that's a very, so I will tell you that we've had a tremendous difficulty moving elbows that have gotten stuck after surgery. And I think, if you can think of an accident as and surgery, they're both different kinds of trauma, right? They're both different things that will cause inflammation and scarring. And children and adults with arthrogryposis, they can form scar just like everybody else, but they don't have really, generally they lack, or you would lack the musculature to be able to keep your elbow moving, which keeps that scar from forming. The common expression is a rolling stone grows no moss, right? So as long as the stone is moving, it won't stick. But if the stone gets stuck, it grows moss. And that's the same thing. Any joint that's stuck after a trauma will get stuck permanently. And it's very difficult to release. That's a very serious conversation that we can have offline if you wish to reach out to me.
Dan, you've done excellently. You got one more to go. How important is the amount of time between muscle transfers and beginning of therapy after a muscle transfer?
So important, very important, actually. It depends on which you're doing. So for some things, so for example, for a bipolar latissimus, we'll typically wait 4 to 5 weeks, sometimes 6 weeks to get it moving, because we're in a race between getting the muscle to heal down to the bone and having it heal to its surroundings so that it doesn't move. We do a lot of tricks at the time of surgery to make sure that the muscle envelope is such that it allows gliding of the muscle within the scar. And these are specific things to the surgery. But yeah, generally speaking, you want to move it as fast as you think it's safe to be able to move. There's no rule specifically. Yeah, just principle.
Well, Dan, I really want to thank you for a very engaging talk. You can see from all the questions you got here, a lot of people, oh, one just got added here. Okay, my almost 10-year-old daughter has hit a spot where she doesn't want to do stretches or splints. Have you had children who go through this? Not your own, mind you, this would be your patients. If so, what percent end up needing to reduce surgery? She has had tendon releases on both elbows, and osteoporosis of the left wrist. She has amyoplasia.
Yeah, so generally speaking, by the age of 10, and it obviously depends on when she had her surgery, but generally speaking, by that age, they're active enough and they're using their releases enough, and they're using their arms enough that it doesn't really matter. They don't need formal therapy so much. Life is the therapy. Eating, trying to wipe, trying to get dressed, all these things are going to mobilize the elbow. And so I think as long as she's active, I think formal therapy, if she really hates it, see what happens. I think you can certainly see in a month whether or not it's making any negative effects.
All right, so one more snuck in under the wire here, and we'll call this the last one. their child has osteoporotic and elbow extension contracture. Last time she tried elbow flexion bracing, she had a growth plate break. Scared to try again. What are your suggestions?
Yeah. So how old is it? Doesn't, well, I can't ask a question, so I'm sort of stuck. So this is a child who has elbow flexion bracing and had probably an olecranon fracture or something along those lines. An olecranon sleeve fracture is my guess, right? That's a problem. The difficulty is this is why we try to get the elbows released at a younger age. If it happens before the age of 1, I think you still have a lot of potential. If it happens after the age of 1, then I would say, unfortunately, not try to get that elbow released as soon as you can.
All right. So the fairy godmother just said this child is 11.
Yeah. So, and the child has not had an elbow release. So is my guess. I think, it is hard to undo things that weren't done at the time that they should have been done. And that's all I can say. It's difficult. It's difficult when we miss the windows.
So and then we also, fairy godmother put in that there's been no elbow release. Would this be a consideration then once things have healed up to do an elbow release?
At 11 years old, an elbow release is very difficult to get right. And it's not from a surgical standpoint, it's just the body doesn't want to move anymore. I've had quite a few patients that I've done at like 15 and older, and some of them had great results, but it's very unpredictable. And I'm sure I have a lot of people listening who are like, I don't know, he did my elbow release when I was 10 and I did great. And I have probably an equal number of patients who are, yeah, he did me when I was 10 years old and I didn't do that well. It's true. I think that the earlier you get to them, the better. And so if anyone's listening with young children under a year of age or even older than that, and they don't have elbow flexion, that should be your priority.
All right. So once again, I just want to thank you for your talk and thank you for your time. You did a great job of taking a very complex and broad topic and bringing it down to a level where even I can understand it well. So it was very enjoyable, and I'm sure you have a lot of people reaching out to you. And having said that, about 5 minutes ago, I got a note saying we'll take a 10-minute break. So we're probably down to maybe 7 minutes now. Jean, what do you want to call it?
I think 7 minutes sounds like a great idea. So during that break time, I'll go ahead and put a timer up on the screen. I'm going to adjust our timer down to 7 minutes. And then everyone is welcome to step away, get a beverage, whatever they need to do to get ready to resume here when our timer is up in about 7 minutes. So we'll see you all shortly.
Super job, Dan. Thank you.
Oh, thanks, Harold. Yeah, that was great. I don't know if you caught, are we the only ones on?
Nope, we're all still live.
All right, good. Then I won't incriminate myself. But you caught my line. I'm sure you caught my line, Harold.
We will talk tomorrow.
All right, very good.
Take care.
All right, guys. Thank you very much.
Thanks, Dr. Z.
Yeah, it was a pleasure.
Hi, Liam. All right, everybody, we're at the 2-minute mark. So if we were having this at a fancy conference center, we'd have a representative walking through the halls with the little chimes so that you have your last quick drink and come and take your seat. And if you think that time is rushing past you, you're absolutely right, but we got 1 minute left to go. I know what you're thinking. You could listen to that music all evening long. And if our clock was still working, oh, there we go. I guess it's all right. 10, 9, 8, 7, 6, 5, 4, 3, 2, and welcome back. We're now going to listen to our second talk of the evening, From Registry to Telerehabilitation, Guidelines and a New Measure for Children with Arthrogryposis. Where are we at? And this is going to be a team effort. This is through the group over from Montreal, which is a team that I'm very familiar with, headed up by Noémie Dehaan-Ulliot. She's a clinical scientist at the Shriners Hospital for Children in Montreal in Canada. She leads several research studies focusing on improving clinical interventions provided to children with arthrogryposis, and she is the main person who has set up the Arthrogryposis Registry that many of you know about. She is unable to attend with us today, but this is the great team that she leads up because she has plenty of people who can do a great job presenting the information for us. So this session will be presented by Betty oh boy, I'm terrible with this now.
You've never said my name, Harold. Not my last name, at least.
Let's see, Darsaklis.
Darsaklis, really close.
Darsaklis. Oh, so close. I know. I thought if I said it fast, it could sound good. She's an occupational therapist and a clinical researcher, one of the coordinators for the AMC Registry. Then there's Marianne Gagnon, who is a kinesiologist and a doctoral student who completed her master's project on telerehabilitation for children with arthrogryposis. Sarah Cachecho, who is an occupational therapist and a clinical research coordinator on the Rehabilitation Guidelines Project. And then finally, Carolyn Elfassi, who is a doctoral student whose project aims at developing an arthrogryposis-specific measure for the upper limbs. So on behalf of their large research team of dedicated orthopedic surgeons, geneticists, rehabilitation specialists, youths and families, students, researchers, they thank us for inviting them to give a talk today, and we thank you for providing your talk and sharing your time with us.
Thank you so much for that introduction, Harold. So I'm just going to put up our presentation here on the screen so you can all see it. Let's see. It's just a little slow. So as Harold mentioned, we are going to present several of our research projects that we're heading up here in Shriners, Canada tonight with all of you. We will be presenting a few of them. I think it's just taking some time to load. There we go. And so we will be presenting one after the other, and we will be saving questions at the end, kind of like Dr. Zlotolow did. The projects presented today are all part of Dr. Noemi Dan Oliel's AMC research program at Shriners Canada. So she's very sad not to be with us tonight, and she wishes she could be here, but for other reasons she could not attend. But she's interested in research for children with arthrogryposis and has worked with several partners in establishing the first pediatric AMC registry in North America. So the Pediatric Registry for children with AMC is the first topic of our presentation tonight. So the first thing I would like to do is really highlight the huge team that is part of the AMC registry. We have several participating hospitals that we're very lucky to have on board with us. We also have partners across Canada, including Dr. Judy Hall at the University of British Columbia, and some partners in Alberta as well as a geneticist from the University of Illinois in Chicago. So the reason a registry was developed is that typically research in rare diseases is very difficult to conduct. Usually sample sizes are small and it is difficult to make generalizations. So this is especially true in AMC, where the presentation is so varied amongst patient to patient. So before making a large-scale registry involving so many sites, a developmental grant was given to us by the Shriners to validate and pilot registry sets on 40 children presenting with AMC. And this was done at Shriners Canada and at Shriners Philadelphia. So these two sites were purposely selected as they have a relatively large, diverse population of patients with AMC. And thus this provided us the opportunity to explore the contributing factors in the pilot phase. So the preliminary data sets for the pilot were informed by the Canadian CP registry and were reviewed and adapted for AMC by a core group of North American experts. And then it was validated with a wider group of experts across several countries. So the final data sets for the pilot were then piloted on 40 children. And as some of you may know, as some of you may have been participants from the Shriners Canada and from Shriners Philadelphia. So the pilot registry did give us some interesting information. So for example, it showed us that 64% of children with AMC that we had done the pilot registry on were delivered by a C-section. On average, the baby stayed in the hospital for an extra 2 weeks after birth, and that 53%, so just a little over half, were detected in utero. It also showed us that the most affected parts of the body were the hands and the feet, and that almost 1 in 5 children had involvement of some other system, so either the heart, the gastrointestinal system, so digestive system, or the genitourinary system. So this pilot phase helped us identify gaps in the knowledge that we were seeking to collect as well, and to refine the registry data accordingly. So it's actually due to meetings like these and feedbacks that we receive from youth and family of children with AMC that we were able to expand the data that we are collecting in our full-scale registry. So of course we did do literature reviews. However, we did conduct focus groups and individual questionnaires and feedback sessions at annual support group meetings such as this one. And we also held a knowledge exchange day at Shriners Hospital Canada a few years ago to see what is really important to family and youth to collect as information in research. So in total, the voice of over 120 parents and youth were considered, and the outcomes from these knowledge sharing activities identified 5 main research priorities. So one was genetic inheritance, which in turn can help with early diagnosis and screening. The second was identification of outcome measures to evaluate interventions. The third priority was effectiveness of treatment. The fourth priority was physiotherapy and exercise programs. And the final one was the need for longitudinal studies to document outcomes. So these research priorities were not only used to populate the content of the registry, but also to inspire research projects that will be presented later by my colleagues. As a concrete example of how feedback from parents and family members and youth with AMC was incorporated into our project, for example, after the pilot phase, some of the participants said it would be really, really nice to kind of document developmental milestones. And so for the full-scale registry, we decided to incorporate a standardized outcome measure that looks at development in communication, gross motor, fine motor, problem solving, which is the ages and stages. So we decided to incorporate that as a data collection point into our registry. So here is our full-scale registry. We've been funded for 2019 to 2022. We have 3 specific aims. So our first aim is to identify the underlying causes, risk factors, and distribution of AMC. Our second aim is to develop a platform to document interventions and functional outcomes. And the third aim is to determine the genetic causes of AMC within a research context, of course. So for each aim, we have a subset of outcome measures to collect the appropriate information. So there's actually a lot of questionnaires in our AMC registry and a lot of different data points that we're looking at. There are some outcomes that are clinician administered. So either the physiotherapist, occupational therapist, or the physician may be involved in administering these. But we also opted for a lot of patient-reported outcomes to truly gather the experience of each child with AMC. So as part of the registry, the clinical information gathered, as well as the photographs, because we do take a specific set of photographs, are shared with the geneticists. So then the participants may then be approached to participate in part 2 of the registry, which is to answer the genetic portion. And that includes providing a small saliva sample, and we do whole genome sequencing to help identify the genes that are causing AMC. So again, this is within a research perspective. So it's all within a research protocol, and we do the whole genome sequencing at Shriners in Tampa. Initially, for our full registry, we did start with only 4 sites. So it was, we only kept it within Shriners sites because it is a Shriners grant. So we started with Canada, Philadelphia, Northern California, and Portland. However, we've been lucky enough to now be able to include Greenville, Chicago, and Honolulu as well. All sites are now open and accepting participants for new participants for the registry. So just to give you all a little update, so far for part 1, and that's where we kind of just collect information on the pregnancy and newborn stage, on current mobility, ADLs, so self-care, cognition, development, range of motion. We have 237 participants, and our initial target was 300. So if we can even surpass our target, that would be really wonderful, because the more data we have, the more information we're collecting, and the more conclusions and future venues for research we can inspire. For part 2, we have 52 participants to date. So this is the part where we ask participants to provide saliva samples that we then send for whole genome sequencing to Tampa, Shriners in Tampa. And 42 of the 52 participants have already provided saliva samples. And sometimes it's just of the child. Sometimes we ask of the child and the biological parents if we're looking for more of an inheritance pattern. So that's for that. Moving forward, we do hope to collaborate with our international partners from various backgrounds. So either patient support networks, pediatric neurologists, geneticists, and bioinformaticians, to name a few. So right now we're very orthopedic oriented because we are based in the Shriners, but we have had some encouraging conversations with colleagues from Switzerland, France, and Spain who are also interested in establishing a pediatric AMC registry in their countries. So by working together, we hope to create a baseline of minimal information that we can collect at all sites in all countries to ensure that the results from the registry can expand research and clinical care for the entire community globally. So on that note, I'd like to introduce my colleague, Marianne, who had a pivotal part in the telerehabilitation project done at the Shriners, at Shriners Canada specifically, with youth with AMC.
So I am Marianne. I will present you the telerehabilitation project that we completed in March 2020, so just before the pandemic. So we can switch slide. So, and we just recently published the results from this study. So the study is completed. So here you can see all the things that was involved in that project. And we would like to thank the Canadian Musculoskeletal Rehab Research Network for the funding of this project. So as Betty mentioned in our presentation, in 2016, during the Knowledge Exchange Day, one of the priorities raised by the different stakeholders was that they want to know more about the effect of exercise and physical therapy. So in AMC, it is known that if a joint is not used, it may lead to further difficulty with achieving full range of motion. We also think that exercise has some potential benefits for individuals with AMC, but little is known about that in the literature now. So we think that exercise can help to maintain or increase range of motion, muscle strength, or help for pain relief. You can switch. However, one of the challenges that we face when we want to implement an exercise intervention is that individuals with rare conditions such as AMC often live far from their specialized healthcare center. So it is hard and expensive to provide them a regular intervention, such as an exercise intervention that require frequent follow-ups. Switch. So telerehabilitation, which consists of remote delivery of rehabilitation services, may offer a potential solution. Maybe you experienced that the telerehabilitation approach during the last year because it became very popular, but our project happens before the pandemic. So telerehabilitation has been shown to be feasible with adults, but there is a lack of knowledge on its feasibility with children and adolescents with a musculoskeletal condition. But we think it's a potential solution. Switch. So the objective of our project was to assess the feasibility of using telerehabilitation, so a video conferencing system to provide an assessment and an exercise intervention remotely. We also want to explore the effectiveness of an exercise intervention. Next. So in our project, we included those with a diagnosis of AMC, aged from 8 to 21 years old, that were able to understand French or English and living in Canada. We excluded those with a recent surgery, so 6 months for bony surgery and 3 months for soft tissue surgery, and those with a cognitive deficit. Next. So the intervention consisted in a 12 weeks home-based exercise intervention. So before the start of the intervention, our participants had to complete online questionnaires about their level of function, physical activity, and pain. And after they had a meeting with an occupational therapist and a physical therapist where they assessed their range of motion. So we measure with the camera the range of motion, and they asked also the different questions about their daily activities. With all those results, the therapist and the participants established some individualized objectives on which the exercise program was based. 1 week later, the physical rehabilitation therapist explained all their exercise and make sure they were well understood and performed and safe. And follow-ups were provided at 3, 6, and 9 weeks to make sure the exercise were safe and well performed, and also to increase or decrease the level of difficulty of each exercise as needed. At the end of the 12 weeks, the participants completed the same questionnaires with the addition of questions about their satisfaction, and we also assess again their range of motion, and we determine if they achieved their objectives. Next. So from 114 patients with AMC follow at the Shriners Hospital for Children in Canada, 41 were eligible, and we recruited 10 participants. We also recruited 1 extra participant via social networks. So in total, 11 participants were recruited, but 7 completed the intervention. So you can see here a QR code that you can scan to access the publication of this project that was published 2 weeks ago. And in the additional material, you have access to a few examples of the exercise that we provided to our participants. Next. So here you have a table that summarized the 7 participants that completed the study. So 5 male and 2 female completed the intervention. The average age was 16.9 years old, and where they lived, the distance ranged from 7 to more than 3,000 kilometers from the hospital. So it was a broad in range in distance. and the level of mobility varied among our participants. For the goals, it was very various, but overall, the goals aim at improving autonomy, endurance, and pain management. Next. So to assess the feasibility of the intervention, we established some operationalization criteria, and all were reached except the recruitment rate that was lower than the 50% expected. So our participants completed their exercise on average twice a week, while we asked them to perform them 3 times a week. So it corresponds to the compliance. And as you probably experienced in the past year with the use of Zoom or Skype, some technical issues can arise, and it's happened in 5 out of our 47th meeting, but all were resolved during the same meeting. So we didn't have to cancel a meeting with our participants. Next. So for their satisfaction, we asked them to mention what they like, what they want to improve. And one participant mentioned that he liked everything. And another mentioned that one major improvement would be to increase the span of the program from 12 weeks to 12 months, which testimony how I really enjoyed the intervention. Next. So for the effectiveness, we just explored the effectiveness of an exercise intervention, as we only had 7 participants, but each participant had from 1 to 3 goals for a total of 15 goals, and 12 out of the 15 goals were achieved. Next. So with this pilot study, we learned that we still need to improve the recruitment procedure, and you can help us by giving your suggestion on how we can approach you to propose you some research project. Next. And in conclusion, we also learned that telerehabilitation works well for individuals living across Canada with a different level of mobility and various goals. Next. So here you can see some example of the exercise that we provided to our participants. Next. So in conclusion, I would like to thank for your attention, and I would like to introduce you to my colleague Sarah Cachecho, that will present about the development of rehabilitation guidelines. She got married, so it will be a pre-recorded video. Thank you.
Yes, so as Marianne mentioned, Sarah could not be with us here tonight because her wedding is actually upcoming just in a couple of days. But we are lucky enough to have had one of her pre-recorded presentations that she did for another conference. And actually, so this project is a little special because there were patient partners, and so youth or family members of children with AMC that were used to actually develop the study procedures and the study protocol, so that they were really integrated right from the beginning, right from the development of the research project. So in this video, you will actually see one of the patient partners who helped in the development of this project. His name is Francis. He does give a little, he does contribute, but it is in French because we live in Quebec, and in Quebec, a lot of people do speak French. So at the very end, I've translated what he says, and I'll share it with the group. So.
My name is Sarah. I'm an occupational therapist at the Shriners Hospital, also working in clinical research. And I'll present to you the poster for our DARE project, or Developing Arthrogryposis Rehabilitation Expert Guidance. Arthrogryposis is a group of congenital disorders where a child is born with joint contractures in multiple areas in their body. These contractures can have an impact on the child's ability to mobilize and participate in various daily activities. This is why rehabilitation has to start very early on in the child's life to minimize those contractures and maximize potential for autonomy. It can be hard for clinicians to develop experience with this clientele because arthrogryposis is rare and they might have a small number of these children on their caseload. And also research evidence supporting best practice in rehabilitation is limited. So the goal of this project is to develop rehabilitation expert guidance or recommendations based on expert opinion for how to evaluate and treat children with arthrogryposis across 5 areas previously identified as priorities by youth with arthrogryposis, their families, and clinicians. And these areas include pain, muscle and joint function, self-care, mobility, and participation. For this project, we're using an integrated knowledge translation approach. We have an international team of clinicians, a young adult with arthrogryposis, a parent, and researchers and methodology experts engaged in all of the steps of the project. I'll let Francis, one of our partners on this project, talk a little bit more about that.
My name is Francis. I'm an orthotist and also a patient with arthrogryposis. I'm an avid athlete and I play sledge hockey on a provincial and national level. I was invited to collaborate in the DARE project. It is very interesting to have a team with multiple backgrounds and points of view regarding AMC, which is critical in achieving a better understanding of what is happening in the current management of AMC. Having patients and parents of patients involved in the project team is also important to gain a better understanding of the psychological implications of certain treatments so that a more thorough understanding of the day-to-day of patients with arthrogryposis can be achieved. The importance of having such a varied team, and by this I mean clinicians, researchers, patients, families of patients, and support groups, is critical throughout the entire process of the development of guidelines to have a thorough understanding of their implications and the pertinence upon application. This will also facilitate the acceptance and implementation of the recommendations and treatment plan if the patient understands that these guidelines were developed in conjunction with other patients and families of patients.
So the first step of the project is to identify the current rehabilitation practices in arthrogryposis. So clinicians worldwide were invited to participate in a survey. We've had responses from 10 different countries, mainly rehab practitioners, and this has helped determine the most frequently used evaluation and treatment approaches in the different priority areas identified previously. The next step is the creation or development of the recommendations. And for this, we've invited clinicians, patient representatives, and researchers from different countries to work together in considering findings from the clinician survey and from the literature to make decisions and develop the rehabilitation recommendations. This is an ongoing process. It's still happening. And here's an example of one of the recommendations that was developed so far. The next steps will help really refine and finalize the statements based on consensus using the modified Delphi approach and the AGREE tool. And once this is completed, we will be identifying facilitators and barriers to knowledge uptake among rehab practitioners working with children with AMC and managers. And this will help guide the knowledge translation strategies for dissemination implementation. And by the end of this, we hope that this will help clinicians in their decision-making when treating children with arthrogryposis.
So that's the end of the short summary for Sarah's project. And so I think Francis really summarizes why this IKT approach was selected for the development of these guidelines. And it's especially true when we consider the AMC population that is very, very devoted, very eager. They look for all kinds of information, and we just, from a clinician standpoint and from a researcher standpoint, I find that the parents are very, very resourceful. And so including them in our research projects is just so critical so that we can always keep our ear to the ground, and also to make sure that what we're doing is really important for everybody and that it will be used once the research is completed. So on this note, I will introduce Carolyn Elfassi, who is sharing her PhD research project.
Alrighty, so hi everyone. Today I'm going to be discussing the Shriners Hospital Arthrogryposis Pediatric Evaluation Upper Extremity, or SHAPE-UP for short, because it's quite a mouthful.
And I think we may have lost her temporarily, if anybody else notices that. So we'll just give her a quick moment. Sometimes the device can freeze for a moment, and then it just takes a second to catch up. But perhaps if we don't hear her come back in, just in the interest of time, oh, do we have her back on?
No.
Okay. All right. Maybe Dr. Vambosa, would you like to take a question or two just in the interest of time while we wait to reconnect with our last speaker?
I think that'd be a great idea. So there's a number of questions that had to do with the registry project. So let me start off with that one, Betty. There was a question saying, are you accepting new patients for the registry?
Yes, all the time.
So what would people have to do if they wanted to become part of this project?
So if you are a patient at any of the Shriners hospitals that are participating, you could just contact your doctor and they will contact the clinical research coordinator who is in charge of the registry, and they can recruit you. And actually, I didn't really talk about it, but we did move towards remote recruitment because of COVID. Some of the hospitals were shut down. The research was kind of slowed. So we didn't want to lose our momentum because a lot of the families were excited about the idea of a registry. And so, you know, we also call families to recruit them over the phone. We can do the questionnaires online. We can do the questionnaires over the phone. So we have multiple ways that we can collect the information. So all you have to do is reach out to the Shriners Hospital that you are followed by. And someone will be very eager to reach out to you and make sure that if you're interested to participate, you can.
And that kind of dovetails a little bit with another question that came up from somebody from Boston, which says that they're not currently being seen at a Shriners facility. They have been seen at a few different places in Boston, including the wonderful Boston Children's Hospital, which is a great place. But really what you're saying is they need to be some way integrated within the Shriners system.
Yes, unfortunately for the moment, because our grant did come from the Shriners, so we are only accepting from the Shriners for now. But as I mentioned at the end, we are looking to expand globally, but also within North America with other great hospitals like the Boston Children's Hospital. So nothing is off the table. So if you can't participate now, our hope is to be able to continue this past 2022 and continue.
And then let me ask you for a little clarification there. So you mentioned whole genome sequencing. Can you tell us a little bit what whole genome sequencing is?
Yes, so whole genome sequencing, I'm just an OT. I'm just going to start with that. Whole genome sequencing is a type of genetic analysis. So I'll just wrap up this answer. Whole genome sequencing is a type of genetic analysis. It's actually the most advanced genetic analysis that we have to date, that kind of looks at the DNA across the entire gene. So there's some genetic analyses out there that just look at specific genes or at specific parts of the DNA or the chromosomes. But this really looks at the whole genome, so all of your DNA, to see what kind of variations may exist that may contribute to, in this case, explaining arthrogryposis.
Yeah, I agree with you. And I think that it's really the state-of-the-art testing now. Hopefully there'll be more exciting types of testing that come up in the future, but it's better than, for example, the batteries, the testing batteries that people have come up with before that only checked, 40 or 50 different genes. Here we're looking at everything that's in the genome. But it looks like we've got Caroline back. So
sorry about that. Of course, everything works perfectly. We did the trial run, and then the second I'm supposed to talk, bam, nothing works.
Just for you.
Okay, well, I'm back and hopefully everything works. So, okay, just to get back into it, so that we don't waste any more time. Today, I'm just going to be discussing the SHAPE-UP, as I mentioned. just wanted to give a big shout out to this wonderful team that's helping with this project. So we're 6 different Shriner sites from Canada and then across the States, as well as working with 2 supervisors from McGill University and Université de Montréal. So next slide. So just a quick overview of what the study objectives are at large. Overall is to develop this new upper extremity outcome measure. So instead of looking at these boring words, we're going to look at this pretty picture that's up next to basically say the same thing, that this project is funded over 3 years, but before we started the first aim, we kind of had some preliminary work that we went over that I'm going to be discussing in the next slides. So the first preliminary or research work that we did was a scoping review, looking at identifying all the pediatric upper extremity performance-based outcome measures, and then mapping those measures and those items to the International Classification of Functioning, Disability, and Health, Child and Youth. So basically, that's all to say that this is a fancy framework that a lot of clinicians use to identify certain limitations or impairments or activity restrictions. So for example, here I put, just like, for example, body functions, it would be a physical problem, which in this case, we could say like an elbow is not bending or is not extending. How does that translate into an activity? So that would limit feeding or wiping, and then how does that translate into the participation of the day-to-day life as well? That's influenced by environmental factors and personal factors. So what we did was look into the literature to identify all those measures that identify those tasks. So if we look into the next slide, I'm going to save you from the lengthy process that was this research project and just give you the funneled version. So we looked at 5,564 articles. And once we narrowed it down based off of our search criteria and selection criteria, we were able to identify 27 outcome measures. And then from these 27 outcome measures, we identified 510 items or activities that were then mapped to that framework that I just spoke about. So an activity or an item could be, cutting or playing or throwing a ball or, feeding yourself, etc. So next slide. Yep. So then what we did is we used those items or those activity and we coded them based off of a specific coding scheme that went all the way down to a 4th level code. So here we see that we have body functions, that's broken down, the activities that's broken down, and then how does that break down even more. And then based on those results, if you press the next slide, yep, you could see that the most frequently identified codes were fine hand use, fine hand manipulation, grasp, and voluntary movement. So that's kind of the first what's in the literature phase. Next, we looked at the nominal group technique. So the second portion of this preliminary work was you guys, essentially, was the patient and the stakeholder engagement. And we achieved this by performing this nominal group technique at the 14th AMCSI conference, back when we were allowed to, congregate and be with people and see people and meet people. So that was in July of 2019. There were 11 individuals. So we had different parents with children varying ages with AMC, and then 1 adult with AMC that participated. And we asked them the question, when a therapist or rehabilitation professional is assessing you or your child's arms, shoulders, elbows, wrists, hands, fingers, what do you think is an important aspect or item to consider in this evaluation? It could be a simple task or an activity that requires many steps. So after a series of discussions and voting, the group identified the following results. So we identified 33 items or tasks or activities. And based on the voting, these were the 5 top most voted. So there was getting out of bed, reaching mouth, dressing, picking up an object, and just reaching age-appropriate milestones. So now is the fun part of combining those 2 phases, or combining what we found in the literature plus what was advocated during our stakeholder engagement, and creating this preliminary prototype of this shape up. So what we're doing is we're actually creating a survey by combining what we found in the literature plus what was said in that knowledge, that nominal group. So we're creating a survey and we're going to be sending it out to different clinicians, basically internationally. And then based off of their responses of the items and the activities, we're going to be modifying and tweaking and adapting, removing, editing those items, those words, to make sure we reflect the right things that we want to evaluate when evaluating, the upper extremity, when evaluating that movement. So we're going to keep going. Hopefully 3 rounds will give us a consensus, but if need be, until we have what we're going to call the final prototype version of the shape up. At which point, if we go to the next phase, phase 2, we're going to have the cross-sectional study where the fun part of recruiting comes into play, because now we're going to be recruiting approximately 120 different children or participants with AMC from 6 different Shriners sites. So we have Shriners Canada, Greenville, Philadelphia, Northern California, Portland, and Chicago. We're going to be including anybody who has a diagnosis of AMC, essentially, except for children between 0 and 1, because as Dr. Z has said before, and I'm sure in the previous talks, usually the 0 to 1 age is a little bit more of a conservative treatment of just stretching and splinting and bracing. So we wanted to know, in terms of the evaluation, how would that affect them? So hopefully by the end of this phase, once we have our 120 participants, we're able to run a very fancy analysis that I'm not even going to get into because it's too fancy for me too. And that will give us the final version of the shape up. So that will give us the final version of the shape up, at which point we can then establish the classic psychometric properties. So we're basically going to be looking at the statistics and the analysis of the measure itself. So we want to make sure that it's valid and reliable, which is to say that we want to make sure that the shape up is stable over time and across different administrations by different clinicians, and that it measures what it was actually developed or intended to measure, which in this case would be upper extremity function. So this is a big project. It's over a 3-year span, and this is kind of the condensed and shortened version. So if you guys have any questions, I'd love to answer any of them. So here is everybody. Oh, next slide, I guess, is everybody's information. I'm sure you have, if you have anything, you feel free to email any or all of us, and we will love to answer anything.
So I know that there are already some questions in the chat that Harold was summarizing so kindly for us, but we do have a couple of questions up here as well. If you want to chime in the chat and provide some answers, or the moderators, Jean will do a great job at summarizing your answers to these questions too. But these are more discussion points if we run out of questions.
Okay, so I'm going to chime in here and just let the audience know that they can continue to send in questions or comments in the meeting chat. But as noted, if they don't have any questions for our speakers, the speakers have turned the tables and posed some questions for you. So you can certainly feel free to share your own responses to these individual questions. I did want to ask our speakers, there was an activity or set of poll questions. Would you like to call those up now before we launch into the Q&A with the audience?
Sure. Yes. And yeah, I mean, you guys can multitask and do everything at once. That would be great.
All right. So I'm going to go ahead and put a poll window up on the screen, and there'll be a series of 3 questions on the screen for you today. So you can simply scroll through and cast your vote. Simply click the circle to the answer that you wish, go through to each of the 3 questions, and then hit the submit button. And I know that this information will be very helpful to our speakers team. So I'm going to express their gratitude in advance for you responding to this particular poll. So I think while we let people respond there, and then perhaps some people formulate their thoughts in the questions you have on the screen, Dr. Van Bossa, would you like to start taking a couple of the questions that we have in the chat, just in the interest of time?
I think that'd be a great idea. And hopefully I'm not muted. Good. So let's start off here with, so some questions are a little specific, and we'll see how best you guys can do at answering. So here's the question. Says, I'm in Vancouver, British Columbia. Is there someone here that is familiar with AMC? I have not had a doctor. The last doctor apparently was Michael Bell at Children's, and haven't had a doctor in 20 years. So who should this person now see that they're 42 years old? What suggestions do you have? Probably not a real specific one, but just kind of in general. What would you suggest?
I'm not really sure about who's doing adult clinically. I do know about adult research. So maybe, I mean, what I would actually recommend is reaching out to Bonnie, Dr. Bonita Sawatsky. She has AMC. She also does research in AMC, and maybe she could link to someone who does adult medicine in British Columbia.
And where is she at? Do you know?
She's at the University of British Columbia.
And she's also a co-author on a number of the papers that you guys were showing. So
Absolutely.
If nothing else, that might spur people on to go take a look at those papers. And yeah, so also, if I can chime in here, what I usually recommend to the patients who are aging out of my practice is that they not look for an orthopedist, but they actually look for a physiatrist.
Yes.
An orthopedist is in adults, orthopedics are very episodic. They're looking to treat you for your hip problem, your knee problem, and they're not really good on treating the overall patient and kind of carrying you along. Whereas a physiatrist, that's more their orientation. So that would be my 2 cents there. And certainly with this wealth of occupational therapists, you guys probably have a little bit more of an idea also. What do you say just in general to your adult patients when they age out of the Shrine system?
We do exactly the same thing. We do refer, so here we have rehabilitation centers where you have physiotherapists, occupational therapists, and so we do refer them there. And usually on the adult side, there's a physiatrist, even on the pediatric side, that oversees everything because it's exactly the same, at least here in Quebec, but in most places of Canada, orthopedists are really like, if you need a knee replacement, hip replacement, if you need a surgery, and then they kind of discharge you, but the physiatrist will look over your care. So I think it's physiatrist or physical medicine, doctor of physical medicine as well. So that is usually what we do here as well.
Okay, now, real quickly, there was a shout out from Dallas. She wants to send her love to Betty. That's Dallas, the person, not Dallas, the city, just so everybody knows. Looking forward to the next research steps, which brings us around to somebody who's got a very more of a kind of a community-based question here. Have you tried to use the pilot registry to help AMCers connect with each other? Sounds like you have a list of AMCers that might truly benefit by connecting with each other. Now, I'm going to let you talk a little bit from the standpoint of protecting personal information, but also from the standpoint of connecting people.
Yes, absolutely. So unfortunately, yes, we do have, fortunately, we do have a list of AMCers that we would love to connect with each other, but because of research and codes of ethics, we do need to respect patient confidentiality. It's not, often we will see like, oh, this family is similar to this family, or they're living through the same kind of developmental milestones that, we would love to connect, but we cannot use our research data in any way to have families connect to each other. That being said, we do have at the Shriners an AMC clinic, so where multiple patients with AMC are seen on the same day. And so during those days, we do try, not as researchers, but I know the clinicians do try to kind of match families so that, maybe you have a more, like an older youth, maybe late teens, and a younger child maybe newly diagnosed with AMC, or like 2, 3 years old and the parents are struggling, so you can have those parents meet. We try to have them, because at Shriners Canada, we're also lucky that we are the one for Canada. So they do come from all over. So if you can, sometimes we have families from out east all come at the same time, or out west. So we do try to connect patients that way. And of course, we always refer them to AMCSI too, because it is the best way we find in North America, to connect and be with each other.
That's kind of the upside of having a very busy clinic day, where you have a lot of people sitting in the waiting room, because it kind of becomes a de facto support group and a social experience.
Yes.
So, and then there's an addendum to that question. Can you add that as a next question agreement in your registry to let people permit you to use their data for that purpose, apparently the purpose of connecting? Would that be a possibility, or is that something that's on the hard side to do?
You know what? We could definitely add it. We could look into it with our ethics boards. Having a registry in Canada and the US, we've learned a lot about each other's ethics boards, I think. There are some things that fly in certain countries and certain provinces that don't fly in others, but that is definitely a great suggestion, and we will look into how we can use that for sure.
All right, so next question is, with 400 plus types of arthrogryposis, are there specific ones you are focusing on?
No, we are not focusing on any, actually. So for the registry specifically, we are just trying to catch as many participants who are willing to participate, really.
And even with the other projects, we kind of left it open to basically a diagnosis with AMC. That's that.
Yeah, if we started, so first of all, I don't think that clinically people are far enough along to be able to always say exactly what kind of arthrogryposis is had. The 400, I also feel like the 400 refers to the amount of genes, but several genes can be the cause of the same type of arthrogryposis. So for now, because research, we're trying to kind of build it up, we want to really leave it as broad as possible so that we could get as much information as possible. And then as it becomes more refined, for sure, we could tailor it down.
Mm-hmm.
And I also want to add, though, that this is also allowed for some specific look into different conditions. Can any of you address what we just did with the Escobar patients?
Yes, so actually we did, so from our registry, we were able to pool exactly what Harold said, the Escobar patients, so that we can look at scoliosis, and the progression of the curve, and the genetic markers. So from there, from our registry, we are hoping to be able to make subgroups, but that is why we're casting kind of for everybody, because then we can kind of develop these subgroups according to diagnosis if we have enough. But if we, right from the start, kind of go in narrow, we may not be able to gather enough information to be able to make those specific sub-studies.
Next question is there an age cutoff for children in the study?
In the registry?
Yeah.
Feel like I'm talking a lot. No. So we're recruiting right up until 21. So if you're 21 and 363 days, you can participate.
Same thing for the shape up measure.
And for the shape up measure, how do you see that being used in the future? So when you have your project all finished and it gets into the hands of some sweaty upper extremity surgeon, what are they going to do with it?
So the ideal would be to have it as a pre-post measure, to kind of have as a baseline measurement before they have a surgery, or the kids have a surgery, so that we see how they're kind of scoring or how they're performing. And then post-surgery, if that score changed, and does that change reflect an increase in autonomy and ADL and stuff like that. So it's kind of like the SHUI for CP of AMC, hopefully.
And when you had those 5 activities, when you asked patients, were those ranked in any order, or were those just 5 activities in general that they were just in?
Rank. Yeah, that was from most. It was the top 5, but the first one was the most frequently one.
So did it surprise you that the top one was getting out of bed versus, for example, toilet hygiene or eating?
It was a surprise for sure, but I feel like with the discussion, that was kind of just the title that we gave it. But with the discussion, it was more of the transfers, mobility aspect, using your upper extremities specifically. More than just physically the getting out of bed component. It was, getting out of bed, but also going from, let's say, if you're in a wheelchair to sitting on the toilet, or from the toilet back up, etc. So it was that whole umbrella.
And then Marianne, what types of goals seem to do the best at being fulfilled with the telerehabilitation method?
Yes, so it's a good question. So the goals that were, like most of the goals that were achieved beyond the expectation. So the goals about the endurance work well. So we had some patients that improved so well in just 3 weeks. And the goals related to pain was harder to achieve, probably just because they had pain since a while, like since many years, and it maybe need a better, not a better team, but a more multidisciplinary team with different therapists to help to improve the pain management exercise. But yeah, the goals about strength and endurance works really well.
Oh, good. All right, so we got only a few minutes left. So I'm going to do a rapid fire round here, Betty. Was your research delayed or impacted by COVID?
It was impacted a little bit, but that is why we moved to the remote recruitment, which we're really, really grateful for, actually, because it's allowing us to reach even more patients and participants this way. So we are able to call families now and recruit them if they belong to a Shriners Hospital over the phone. For part 1, we don't even need a signature, but for part 2, because DNA is involved and there's genetic testing, that is a little bit more sensitive. And then we do need to get that signature, a physical signature. So maybe part 2 was a little bit delayed, but part 1, it was actually a blessing in disguise.
Okay, and then the next one was, I sent in blood to Shriners Montreal around end June. How long does it take to get results?
I hope it was saliva. So right now we're sending, so once we send it to once you send it to Shriners Montreal, we do send it off to Tampa. They do have a little bit of a backlog, but as soon as they complete the sequencing, we have our bioinformatician look at it, and we share the report as soon as we have it. So right now we're looking at a bit of a delay, but it really depends on how long it takes for the Tampa turnaround.
Okay. And the next one is actually a very interesting one because it's got part sociology baked into it here. Good job, speakers. I think a key question for the AMC registry, once it expands beyond Shriners, would be about the financial cost of AMC over a child's lifetime. We are not in the Shriners system and we have good insurance for the states, but we are routinely hit with our $10,000 annual cap. We have also had a physiatrist recommend a brace that would have cost us another $10,000 if we hadn't already met our cap. I think it would be critical to understand whether people with AMC and their families have medical debts or stressors from this condition, and what's the surgeries, OT and PT and the durable medical equipment costs are for families and people with AMC, so we can advocate for better coverage of these items. And I'll just throw onto that, or we can all move to Canada.
Even in Canada, it's not ideal, but that is actually one of our we're really excited about that topic, because I think it's a very, very important topic. The financial burden, whether or not you're in the US, Canada, or elsewhere, for AMC, there's a lot of surgery, there's a lot of rehab. And even if it doesn't come out as braces or adaptive equipment, it's time off of work, it's time spending doing the exercises. The financial burden is a very, very serious consideration, and we're very interested in looking at it. We just haven't found the right moment to write the proposal for the right funding agency so that we can really do this properly. But that is an excellent question. Absolutely. Very interesting. I agree.
With large implications. Okay, one last question. It says, I think it would be great to look at adaptive sports or alternative activities / teams that AMCers may be involved in. Would be great to see and track if that has an impact on their movement long term.
Yes, agreed as well. And I think that's something that Marianne's project can speak to too. I mean, right now I find that the adapted sports is very, in our case, very province by province, and even within the same province, region by region, certain regions are better serviced than others. But definitely as an OT and as a researcher, you're speaking to my heart here. Getting people involved in leisure and active and moving, and not just from a physical standpoint, but also a social standpoint is super important. And there have been studies in CP, cerebral palsy, that look at participation in leisure activities and trying to kind of network, adapt apps that kind of show you what is available in your region. But the fact remains that sometimes those resources are very, very scarce. So yes, absolutely.
And now the moment you all been waiting for, when Jean can tell us what everybody was drinking tonight.
All right, I'm going to go ahead and end that poll, and let's take a quick look at those results. So we'll start with the most important question. Everyone was being good. Water, overwhelmingly. Most of you were drinking water. So glad to see it. But it does look like about a third of the audience, the most popular response is that they'd like to see information presented as in an infographic form, although others are very interested in videos and research manuscripts. And no surprise to me personally, they think that getting that information emailed to them directly would be the best way to get the findings in their hands. But social media seems to work, and they also think it's great to put it on the AMCSI website as well.
Perfect. Thank you so much for that.
Excellent. All right. So I'm going to go ahead and stop sharing these results and close them out. And Dr. Vambosa, I don't see anything else in the queue, and I think we are nearing that special time. So would you like to begin our closeout procedures?
Sure. Let me see where we're supposed to be on those. There we are. I think it's the one where we say, thank you for joining us today. Am I in the right spot?
That's exactly right.
Oh, super. Thank you very much for joining us today. I hope that everybody really enjoyed this. This was our third day of the virtual conference. We're about halfway through. We've got another 3 exciting days left. So don't forget that tomorrow is actually kind of a several teams type day where we have a few different speakers getting together to speak. And then on Friday is the David and David speak with Dr. Frumberg and Dr. Feldman. So it's actually Dave F and Dave F. And then Saturday, late breaking news, Dr. Reed Nichols was not able to give her talk this past Monday. So we've actually made time for her on Saturday. So she will be speaking, I will be speaking, and then comes the very exciting closing ceremony that I hope you'll all be a part of. And I think, sorry, I got to skip through my slides here to get my prompts. And I'm doing this seamlessly so nobody knows I'm actually cheating. So remember as you read out loud, oh, sorry, that's not what I'm supposed to do. So make sure that you please register to attend all the sessions this week. Remember, it's free and open to everyone, so tell your friends. And certainly we always are open for more ideas for the next time around for next year. So if you have some ideas that you came up with for speakers that you want to hear from, let us know. So we hope you can join us tomorrow. Our next set of talks are the Super Suits Move to Learn Innovation Lab. That's from the University of Delaware. And the other one is the Multimodal Treatment for Early Intervention. And remember that we announced the location for our 2022 annual conference when? Saturday after my talk. So please don't miss it. And I will now leave it to our technical moderator to say,
well, folks, that is a wrap. So I want to just say thank you to each and every one of you, to our fabulous presenters, our just absolutely wonderful facilitator and the amazing support team that's been on in the background throughout this whole thing, as well as each and every one of you who joined us online, as well as those watching on social media. So I am going to go ahead and close it out for the night. We're getting lots of really big thank yous in the chat message. They found this really informative, and they just are just so grateful that you all have come on and shared your talks tonight. So thank you from the live audience. All right, with that, it's really a wrap. So good evening, everybody. Go ahead and hit that red button in the lower corner, and you can leave the meeting, and we'll hopefully see you here tomorrow as we carry on with the virtual conference.